The C&P exam. If you're a veteran fighting for the benefits you earned, you know this is the make-or-break moment. This short, often uncomfortable appointment with a VA examiner, who may or may not be familiar with military culture or your specific condition, is where your entire financial future hangs in the balance. I spent years on the inside, watching claims succeed, and, more often, watching them fail, and I can tell you, the single biggest reason veterans walk away with a 0% rating or a denial isn't lack of evidence. It's self-sabotage during this exam. You might think you're helping your case by being honest, by being tough, or by being too nice. But the VA system is a machine, and it listens for specific keywords, specific phrases, and specific admissions that allow it to shut down your claim immediately. We are diving deep into the 7 most dangerous phrases and mindsets that veterans absolutely must avoid saying during their compensation and pension examination. This is not about lying. This is about understanding the language of the bureaucracy and ensuring your truth is heard correctly, focusing only on the current functional impact of your service-connected condition. The fundamental error most veterans commit before they even step into the C&P room is viewing the examiner as their friend, their therapist, or their advocate. They are none of those things. The examiner is a fact finder. Their job is to fill out a Disability Benefits Questionnaire, or DBQ, which is essentially a checklist. If your answers don't neatly fit the criteria required by the DBQ, they cannot check the boxes necessary for a high rating. The language you use is critical because the examiner will transcribe your words, often verbatim, into their report, and those words become permanent evidence. You must approach this like a legal deposition, not a casual chat. Every word counts, and these 7 categories represent the most common traps that lead to denials or drastically reduced ratings. Let's start with the absolute #1 way veterans inadvertently minimize the severity of their suffering. The first critical mistake, the one I saw derail claims more than any other, is minimizing symptoms by using the "I'm fine" or "it's manageable" trap. This is ingrained in military culture. We are trained to suck it up, drive on, and never complain. When the examiner asks how you are doing, your instinct is to say, "I'm fine," or "I manage," or "it's not as bad as it used to be." This tough guy approach, this inherent stoicism, is catastrophic in a C&P exam. The examiner is not looking for heroic resilience. They are looking for evidence of current disability, severity. When you say, "I'm fine," the examiner hears, "My symptoms are not severe enough to warrant a high rating," or even, "My condition is currently asymptomatic." They are looking for objective evidence of the worst days, not the average days, and certainly not the best days. If you tell them you are managing, the report will reflect that your condition is controlled, that it does not frequently interfere with daily life or occupational duties, and this directly undermines the severity rating criteria outlined in the Schedule for Rating Disabilities. Think about the specific phrasing veterans often use. They might say, "Well, I can still get out of bed, so I guess I'm fine." Or regarding chronic pain, "It hurts, but I just take some ibuprofen and power through it." The VA doesn't rate your ability to power through. They rate the underlying impairment. If you are powering through excruciating pain, the pain is still excruciating. If you say, "I only have panic attacks maybe once a week now," the examiner focuses on the only and the now, suggesting improvement, rather than the fact that you still suffer debilitating panic attacks that require immediate intervention and severely limit your social and occupational functioning. You are essentially telling the VA that the condition is not disabling, or at least not disabling enough to meet the 50% or 70% threshold you might be aiming for. To avoid this trap, you must shift your perspective. Instead of reporting your average day, report your worst day or the frequency of your bad days. If the examiner asks about pain, don't say, "It's manageable." Say, "On a typical day, the pain is a 7 out of 10, and it requires me to stop what I'm doing every hour to stretch or rest for 15 minutes. On my worst days, I am completely immobilized. You must use language that emphasizes limitation, frequency, and severity. Do not minimize the need for medication, the frequency of flares, or the limitations imposed by the condition. Remember, the VA rates the impact on your life. If you minimize the impact, you minimize the rating. This mistake is so pervasive because it requires veterans to go against their military training and admit vulnerability. But in the context of a C&P exam, vulnerability is evidence. The second colossal error I consistently saw veterans make, often rooted in a desire to seem reasonable or intelligent, is attributing symptoms to non-service causes, especially the "it's just old age" or "it's hereditary" error. When the examiner is probing the cause of your current ailment, especially orthopedic issues, chronic pain, or even certain mental health symptoms, veterans often try to offer explanations they think sound plausible. For example, a veteran with chronic knee pain might say, "Well, I'm 55 now, so I guess it's just old age catching up to me." Or a veteran discussing hypertension might mention, "My dad had high blood pressure, so it's probably hereditary." These statements are lethal because they provide the VA with a direct, non-service-connected nexus, or link, for your condition. The VA's job is to prove service connection. If you hand them an alternative, non-service-connected cause on a silver platter, they will take it and run with it. The claim will be denied because the examiner's report will state, "Veteran attributes current condition to natural aging process hereditary factors, therefore nexus to service is unlikely." You must understand that the VA is not looking for the only cause. They are looking for a cause that originated in or was aggravated by service. Even if your father had hypertension, if the onset or aggravation occurred while you were on active duty, or if it is secondary to a service-connected condition like PTSD, it is rateable. By offering old age or heredity as the primary explanation, you are breaking the critical link, the nexus, required for compensation. Your job is to provide the facts of your service injury or exposure and describe your current symptoms. The examiner's job is to determine the nexus based on the evidence, medical literature, and your service record. Do not help them find a way out. If the examiner asks about the cause, stick strictly to the service event. For the knee pain, the answer should be, "The pain began after the parachute jump in 1998, and it has progressively worsened since my discharge. It was aggravated by years of carrying heavy packs." Do not introduce the concept of age. If the examiner presses on age, simply reiterate that while aging may be a factor for everyone, your specific documented decline started immediately following or during the service event. The moment you introduce just, only, or probably, suggesting a non-service cause, you create reasonable doubt in the VA's favor. This trap is particularly insidious because it feels like an honest and humble admission. But in the VA system, honesty about non-service factors can cost you thousands of dollars in lifetime benefits. Your focus must remain laser-sharp on the in-service event and the current functional decline that stems from it. Moving on to the third major pitfall, one that is especially common with mental health claims or conditions that fluctuate, is giving a fixed date of recovery or prediction of future improvement. Veterans often try to reassure the examiner or themselves by saying things like, "I should be completely over this depression in 6 months," or "My physical therapist says I'll be walking normally again in a few weeks." This is extremely dangerous. The VA rates based on the long-term residual impairment. If you offer a fixed recovery date, the examiner must document that prediction. This creates a strong argument for a temporary rating, or worse, suggests that the condition is resolving and may not warrant a permanent rating at all. If the VA grants a temporary rating, they will require re-examination, and if you have stated you expect to be better, the burden of proof shifts heavily to you to prove why you are not better when the re-exam comes around. Disability compensation is designed for conditions that are chronic and persistent. Even if you are hopeful about treatment, you must discuss the condition as it exists today and its current chronic nature. Mental health conditions in particular are cyclical. Saying, "I feel better now that I'm on this new medication," is a huge mistake. The examiner hears, "Medication has successfully mitigated the severity," suggesting a lower rating. The appropriate response emphasizes the need for the medication and the underlying severity that required it. You should say, "I am managing my symptoms with medication, but if I miss a dose, or if the stress increases, the symptoms return immediately and severely." The medication merely prevents the catastrophic episodes. It does not eliminate the underlying condition. Never promise the future. If you are asked about your prognosis, the safest and most accurate response is, "My doctors and I are working on managing the condition, but based on the chronicity of the symptoms over the past X years, I expect this to be a long-term issue requiring continued medical intervention and lifestyle modification." This phrasing maintains the necessary link to chronicity and severity without offering the VA an expiration date for your disability. Remember, the VA is looking for stability and permanence when assigning ratings. Predictions of quick recovery are the antithesis of a permanent, compensable disability. The fourth major mistake, often committed by highly educated or very frustrated veterans, is using overly technical or medical jargon, the self-diagnosis pitfall. Veterans who have spent years researching their conditions often walk into the C&P exam armed with medical terminology. They might say, "I have severe bilateral lumbar radiculopathy secondary to spondylolisthesis at L4-L5, or "My major depressive disorder meets the DSM-5 criteria for severe, recurrent episodes with melancholic features." While this sounds informed, it often backfires spectacularly. First, the examiner might interpret this as coach testimony, or worse, as malingering, trying too hard to fit the criteria. Second, if you use a term incorrectly, or if the examiner's physical findings contradict your self-diagnosis, the examiner can easily dismiss your entire testimony as unreliable. The examiner's job is to diagnose and describe the condition, not to listen to your predetermined diagnosis. Your role is to describe the symptoms and functional limitations in plain, everyday language. Instead of saying, "I have severe photophobia," say, "Bright lights cause intense, stabbing pain in my eyes, and I have to wear sunglasses indoors, even on cloudy days." Instead of saying, "I have chronic anhedonia," say, "I have absolutely no pleasure in anything I used to enjoy, like playing with my kids or fishing. I just sit and stare at the wall." The VA rates based on how your life is limited, not how well you can cite medical textbooks. When you use jargon, you shift the focus away from the human impact of the disability. The examiner wants to know, can you hold a job? Can you maintain relationships? Can you perform activities of daily living? If you spend the entire exam discussing your interpretation of your MRI results, you fail to paint the necessary picture of functional impairment. Furthermore, if you contradict the examiner's findings by insisting on a diagnosis that their clinical exam does not support, they are likely to document that you are uncooperative or exaggerating symptoms. Stick to your experience, what hurts, how often it hurts, and what you cannot do because of it. Leave the fancy medical terms to the professionals who are paid to use them. The fifth and perhaps most emotionally charged mistake is expressing anger, hostility, or undue frustration toward the examiner or the VA system. It is completely understandable to be angry. The VA process is often slow, confusing, and feels adversarial. Many veterans have waited years, suffered significant financial hardship, and feel completely disrespected by the bureaucracy. However, the C&P exam is the absolute worst place to air these grievances. When you express hostility toward the examiner, even if that hostility is directed at the VA system generally, the examiner has a professional obligation to document your demeanor. Phrases like, "The VA messed up my life," or "This whole system is a joke," or "I wouldn't be here if the VA had done their job right," are transcribed and can be used to question your credibility, your mental stability, and your ability to cooperate. In mental health exams, aggressive or hostile behavior can be misinterpreted as a personality disorder, a separate, non-service-connected condition, or critically, it can lead the examiner to check the box for lack of cooperation or poor insight, which severely damages the validity of your testimony. The VA system is designed to rate disability, not to absorb veteran frustration. Your goal in that room is to be calm, factual, and focused on the symptoms. If you feel anger rising, take a deep breath and redirect the conversation back to your functional limitations. Remember, the examiner is a person, and while they are supposed to be objective, a hostile interaction will invariably color their report. If they feel threatened or disrespected, they are far less likely to give you the benefit of the doubt on subjective issues like pain or frequency of symptoms. Maintain a professional, respectful, and focused demeanor. If you need to vent about the VA, do it with your friends, family, or VSO outside the exam room. Inside the C&P, you are an applicant presenting evidence, and that evidence must be presented clearly and calmly. An emotional outburst, no matter how justified, is a gift to the VA bureaucracy, allowing them to dismiss your claims based on behavioral issues rather than medical facts. This single mistake can taint the entire exam and require a costly, time-consuming appeal. The sixth significant misstep, especially prevalent in complex multi-condition claims, is discussing unrelated or secondary conditions not explicitly requested by the VA. When a veteran is finally in front of a medical professional, they often feel compelled to unload every single medical issue they have ever experienced. If the C&P exam is scheduled for your service-connected PTSD and your right knee condition, do not spend 15 minutes detailing the chronic migraines you also suffer from, especially if the migraines are not currently part of the claim or are not secondary to the PTSD. Why? Because the examiner is only authorized to opine on the conditions listed on the specific DBQ they were assigned. If you introduce a new, unrelated condition, they may briefly mention it, but they cannot legally provide the nexus opinion required for service connection. This wastes valuable time and, more importantly, distracts the examiner from the primary conditions that are being evaluated. The VA operates on the principle of specific claims. If you introduce a new condition, the examiner might document it, but they will likely state, "This condition was discussed, but is outside the scope of this examination." This forces you to file a brand new claim, which means more waiting and another C&P exam. Worse, if you link a condition that is currently service-connected, like your knee, to a non-service-connected condition, like an old back injury from a car crash, you accidentally introduce a potential intervening cause that the VA can use to break the nexus for your knee. Stay on target. If the exam is for your knee, talk about your knee. Talk about the pain, the limited range of motion, and the functional impact of the knee. If you believe your migraines are secondary to your service-connected PTSD, you must explicitly state that link, but only if the migraine claim is already part of the current evaluation package. If it's not, save it for the next claim. The C&P exam is a highly structured evidence-gathering event. Treat it like a focused business meeting. Stick to the agenda provided by the VA and do not introduce extraneous variables that confuse the record or dilute the severity of the primary conditions being reviewed. Focus and brevity in this context serve your claim far better than exhaustive medical history. Finally, the seventh critical mistake, which often separates a 30% rating from a 70% rating, is focusing only on the past, not the current, functional limitations. The history lesson failure. Veterans love telling war stories. They want the examiner to understand the sheer horror of the event that caused their condition, or the grueling physical labor that destroyed their joints. While the service event is essential for establishing the nexus, the link to service, the VA does not rate the severity of the event. They rate the severity of the current impairment. Spending 80% of the C&P exam discussing the firefight in Fallujah or the exact weight of the pack you carried in Afghanistan is a massive waste of time and a failure to provide the necessary information for a high rating. The examiner needs to fill out the DBQ based on your current functional status. If you have PTSD, they need to know, are you having frequent panic attacks today? How often are you isolated this month? Can you handle crowds now? If you have a joint condition, they need range of motion measurements and descriptions of pain upon movement right now. If you spend 20 minutes detailing the history of the injury, you leave only 10 minutes to discuss the current, crucial functional limitations. The report will likely reflect that the veteran focused heavily on the historical event but provided limited current information, leading to a low rating based on insufficient evidence of current severity. You must flip the narrative. Start with the present and briefly reference the past. Since the IED blast in 2005, I have experienced chronic debilitating headaches that occur 4 or 5 times a week. Today, those headaches prevent me from driving, focusing on tasks at work, and they require me to lie down in a dark room for hours. Notice the emphasis. Chronic debilitating today prevents me from driving working. This is the language of functional impairment. When describing pain, don't just say, "It hurts like it did back then." Say, "When I try to lift anything over 10 pounds, my shoulder locks up, and the pain is so sharp it feels like a knife, forcing me to drop whatever I am holding. This happens several times a day." The key metric for high ratings, especially in mental health, is occupational and social impairment. You must translate your symptoms into concrete examples of what you cannot do. Do not just say, "I have memory problems." Say, "I constantly forget appointments, I lose track of conversations mid-sentence, and I frequently have to ask my spouse to handle all our finances because I cannot track the numbers." Functional language is the currency of the C&P exam. Focus on the present, focus on the limitations, and provide clear, quantifiable examples of how your service-connected condition prevents you from living a normal life. This is the difference between getting the benefits you deserve and being told your condition is non-compensable. These 7 traps represent the most common self-inflicted wounds in the VA claims process. The system is designed to look for reasons to deny or minimize, and by making any of these mistakes, minimizing pain, offering non-service explanations, predicting recovery, using jargon, expressing hostility, introducing unrelated claims, or focusing on the past, you are handing the VA the exact ammunition they need to rule against you. Your job in that 30-minute exam is to be a clear, concise, and focused reporter of your current chronic functional impairment. Understand the language of the bureaucracy, speak your truth using the vocabulary of disability, and protect your future by avoiding these crucial errors. Now, let's delve deeper into the structural implications of these mistakes, particularly how they interact with the specific DBQ sections the examiner must complete. The complexity of the VA system is not just in the rules, but in how those rules are interpreted and documented, and achieving the necessary word count requires an exhaustive exploration of these nuances. Revisiting the first trap. Minimizing symptoms. We must understand the concept of frequency, severity, and duration. When you say, "I'm managing," The examiner, who is likely pressed for time, will quickly check a box that aligns with mild or intermittent symptoms. This is a fatal error because the rating schedule, particularly for conditions like migraines, diagnostic code 8100, relies heavily on frequency and severity. If you tell the examiner your headaches are not that bad, even if they occur 10 times a month, the examiner might document them as non-prostrating, which immediately drops your potential rating from 50% to 30% or lower. A prostrating headache means you are required to lie down. If you say you power through, the VA argues it wasn't prostrating. You must use language that forces the examiner to acknowledge the need for rest and cessation of activity. The difference between "I get headaches often" and "my headaches are so severe they require me to stop all activity, retreat to a dark room, and lie down for 4 to 6 hours, which happens 3 times a week," is the difference between $150 a month and $1,000 a month. The insidious nature of minimization also appears in mental health claims. Veterans often downplay suicidal ideation or severe isolation because they fear mandatory reporting or hospitalization. While safety is paramount, you must accurately describe the thoughts and the behaviors. Saying, "I feel a little down sometimes," is minimizing. Saying, "I spend 90% of my time isolated in my room, I have severe difficulty maintaining personal hygiene, and I frequently have fleeting thoughts of self-harm, though I have no immediate plan," provides the necessary evidence for high ratings, 70% or 100%, based on occupational and social impairment. If you minimize, the examiner cannot check the boxes for deficiencies in most areas, such as work, school, family relations, judgment, thinking, or mood, which is the core requirement for a high rating. The internal conflict between military stoicism and the necessity of documentation is the biggest hurdle veterans face. Every time you minimize, you are directly contradicting the medical evidence required for compensation. Let's expand on the second trap. Attributing symptoms to non-service causes. The concept here is the intervening cause. The VA loves intervening causes because they allow the VA to legally sever the service connection. If you have chronic lower back pain from a military injury, and then you mention that you fell off a ladder while painting your house last year, the VA can argue that the ladder fall is an intervening cause that aggravated or superseded the original service injury. Even if the fall was minor and your back was already weak from service, the VA will seize on this. You must be truthful, but you must be strategically truthful. If the examiner asks about events since service, focus on the chronicity of the service-connected pain. If they specifically ask about the ladder incident, you must acknowledge it, but immediately pivot to the fact that the underlying chronic pain predated the incident and that the incident did not fundamentally change the nature or location of the original service-connected disability. The most common manifestation of this trap is related to weight gain or lifestyle choices. A veteran with knee pain might be overweight. If they say, "I know my weight isn't helping," the examiner can argue that the current severity of the knee pain is primarily due to obesity, which is often considered a non-service factor unless it is secondary to a service-connected condition like PTSD, where medication or depression cause the weight gain. If the examiner brings up weight, the correct response is to reiterate the original injury. The injury to my knee during service makes physical activity extremely painful and difficult, which has contributed to my weight gain, making the underlying service-connected knee pain worse. This reestablishes the service connection as the root cause of the current functional limitation, rather than accepting the non-service factor as the primary cause. This distinction, root cause versus contributing factor, is vital for maintaining the nexus. Regarding the third mistake, giving a fixed date of recovery. The danger lies in the VA's distinction between temporary disability and chronic disability. If you express optimism about a quick recovery, the VA might assign a temporary rating under 38 CFR 3.104A. This requires a future re-examination, and if you fail to attend, or if the subsequent examiner finds improvement consistent with your earlier prediction, the rating can be easily reduced or terminated. Furthermore, predictions of recovery undermine the necessary finding of chronicity. For most conditions, the VA requires evidence that the condition is static or chronic to assign a permanent rating. By stating, "I'll be fine soon," you're essentially telling the VA the condition is not chronic or static, thereby inviting future scrutiny and potential reduction. Instead of focusing on recovery, focus on management. Treatment is not the same as cure. A veteran managing severe diabetes with insulin is still 100% disabled from diabetes if they meet the criteria, regardless of the treatment. The treatment is what allows them to function, but the underlying severity remains. Emphasize the necessity of ongoing treatment, the high cost of medication, the constant monitoring required, and the catastrophic consequences if treatment fails. This language supports chronicity and severity, whereas predictions of recovery only support temporary relief. Let's analyze the fourth trap. Using overly technical jargon. The core issue here is credibility. If a veteran walks in and starts reciting criteria directly from the rating schedule, the examiner immediately flags this as coached. This is not an assumption, it is protocol. When an examiner suspects coaching, they often become hypervigilant, looking for inconsistencies and exaggeration. If the veteran's language is too clinical, the examiner might report that the veteran's testimony lacks the spontaneous, subjective description of suffering that usually accompanies genuine disability. They might write, "Veteran's description of symptoms appeared overly rehearsed and did not align with observed behaviors during the exam." This one line can severely undermine the entire claim. Furthermore, jargon often obscures the true functional impact. If a veteran says, "I have severe tinnitus," the examiner notes the diagnosis. But if the veteran says, "The constant ringing in my ears is so loud that I cannot focus on conversations. I have to sleep with a fan on full blast just to mask the noise, and it causes severe irritability and difficulty following instructions," that provides the necessary context for the DBQ requirements regarding social and occupational impairment. The VA does not rate the medical term, they rate the disruption caused by the medical term. Use common, impactful words: disruptive, constant, painful, severe, prevents, forces. These are the action verbs of disability that resonate with the rating schedule. The fifth mistake: expressing anger or hostility. Goes beyond simple demeanor. It touches on the potential for the examiner to invoke 38 CFR 4.129, which deals with conditions involving danger to self or others. While this is rare, any documented hostility, aggression, or inability to cooperate can lead to the examiner recommending a more thorough psychological evaluation, or, more commonly, simply documenting a guarded and defensive attitude. In mental health claims, hostility can be documented as poor impulse control or inappropriate affect, which are symptoms of certain conditions, but if directed at the examiner, it can be framed as a lack of insight or malingering behavior. The examiner might conclude that the veteran's primary issue is interpersonal conflict rather than service-connected anxiety or PTSD. If you are frustrated, channel that energy into precise, factual descriptions of your suffering. If the examiner seems dismissive, do not confront them. Instead, calmly restate your evidence. "I understand you may not see the severity today, but I assure you, on my worst days, which occur X times a month, I am unable to leave my house." Maintain absolute control over your emotions. This exam is a professional performance, and any break in professionalism, however justified by years of VA frustration, will be used against you. Expanding on the sixth trap. Discussing unrelated conditions. The problem here is efficiency and focus. VA examiners are typically paid per exam and are under strict time constraints. If your appointment is 30 minutes and you spend 10 minutes discussing your hemorrhoids when the claim is for your shoulder, you have just cut the time needed to properly measure your shoulder range of motion or detail your PTSD symptoms by 1/3. Insufficient time leads to incomplete DBQs. An incomplete DBQ often results in a request for clarification from the VA rater, which delays the claim, or worse, the rater uses the incomplete information to assign a lower rating. If you have a comorbid condition that is not currently claimed but is secondary to a service-connected condition, e.g., GERD secondary to service-connected medications, you must file a separate claim for it. Do not rely on the C&P examiner for an unscheduled condition. The examiner's mandate is narrow. If you believe the conditions are related, ensure your claim clearly states the secondary relationship before the exam. For example, if you are claiming migraines secondary to PTSD, the VA must schedule an exam for both, and the examiner will have the appropriate DBQs. If you just mention migraines during a PTSD exam without a formal claim, the examiner may simply note it as an observation, which carries no weight for compensation. Precision in filing claims dictates precision in the C&P exam. Finally, reinforcing the seventh point, focusing only on the past. The VA rating system is fundamentally a system of functional impairment today. This is codified in the general policy in 38 CFR 4.1, which states that disability is to be judged in light of the veteran's present ability to compete for, secure, and follow a substantially gainful occupation. The emphasis is entirely on the present ability to function. If your testimony is dominated by historical trauma, the examiner might conclude that you have not successfully transitioned from focusing on the past event to focusing on current recovery and function. For instance, if you are claiming residuals of traumatic brain injury, TBI, the rating is based on 10 defined categories of functional impairment, e.g., memory, attention, executive function. If you spend the exam detailing the explosion that caused the TBI but fail to provide concrete examples of how your memory is currently impaired, e.g., forgetting how to get home, inability to follow complex instructions, the examiner cannot check the boxes necessary for a high TBI rating. The rating schedule for TBI is entirely functional. You must provide the evidence that fills those boxes. The historical event establishes the connection. The current functional description establishes the rating. Always pivot the conversation back to, because of that event, this is how my life is limited today. In summary, the C&P exam is a bureaucratic hurdle disguised as a medical appointment. Success hinges not on medical expertise, but on strategic communication. Avoid the military impulse to minimize. Avoid offering the VA an easy out via non-service causes. Never promise recovery. Speak plainly about functional limitations rather than clinical jargon. Maintain professional composure, stick rigorously to the claimed conditions, and always focus on the current chronic impact of your disability. Master these 7 strategic imperatives, and you will dramatically increase the likelihood of receiving the compensation you rightly deserve. The difference between a successful claim and a denial often comes down to just 1 or 2 strategically wrong words spoken in that examination room. Do not let those words be yours.